Thank you. Thank you for joining the Complex 2021, the virtual conference meeting. I'm D.W. Park from the Assam Medical Center. We're going to start the main arena live case number 4 session from the new Tokyo hospital from Japan. I'm going to introduce co-moderator Dr. Jun-Jack Chang from Taiwan. I'm going to introduce the worldwide famous panelist from Anthony Young from Hong Kong, Hanbi Park from Korea, and Binoy John from India, Hyung Ko from Japan. Okay, Dr. Jun-Jack Chang, can you introduce the live demonstration also lecture?
Yeah, in the live, I just mentioned Dr. Park is live from the New Tokyo Hospital. And our good friend, very famous, Dr. Sonan Nakamura, will perform the operation for the Impella assisted high-risk PCR. We just call it a chip. It's quite popular and gives the more safety and improve hemodynamic support for the patient to improve the life and quality of life, decrease mortality. And later, then we give the lecture about his experience, maybe with the overview of the clinical trials or data of the Impella or mechanical support for the high-risk PCR. We just mentioned the elective PCR. Thank you.
So I'd like to introduce a case. This is a case of a 53-year-old gentleman with a heart failure on acute and chronic, and this is a post-bypass and an HD patient. Again, 53-year-old gentleman with a heart failure on acute and chronic to post-bypass and 9 years HD patient. Many of the chronic risk factors with a HbA1c 8.6 over IDTM and having a diabetic foot and ulcer and necrosis. However, ABI shows 1.27 in the right, 0.88 in the left. That means proximal is maybe okay. This is okay for Impella. Biliary ejection fraction 39%, anemia, and having a high level of BNP showing more than 700. Very poor general status. Chest XP and ECG more than 70% cardiomegaly with some sign of heart failure. ECG show poor progression in the chest view. If you think about the condition of the level of chip, heart failure, diabetes, HD, multiple disease, complex lesion, CTO, and several severe depressed LVEF, at least a 7-item high-grade chip patient disease. This is the angiogram 10 days ago. Very disease RCF from the proximal and the CTO in the mid. And graft to distal is okay, patent. About resistance, we have a stance in the circumference mid and instance CTO in the distal circumflex. And proximal LAD shows a severe ISR 90% and a stance in the mid CTO. If you look at the later graph, later can provide blood supply to the limited area of the LAD. So this is a plan. At first, concern the general condition, we need to prepare something in the case of emergency. So use Impella. Concerning poor condition of the heart on the HD, we want to decrease the ischemic area as possible as we can. We just want to do something better for him. PCI in a circumference mid and LAD proximal part where Rita did not reach. Point of PCI first. We want to focus on actually with LAD PCI. So all the time we need to confirm our guide wire in the true man. So we need to advance the guide wire to the distal LAD, which only can be confirmed by the Rita angiography. Second, PCI to circumference should be actually minimized. Anyway, this is the last, actually, this is the chest section on admission. And 1 week after PCI, CTR decreased 64% the risk finding of the congestion. And with a significant decrease of BNP and 778 to the 174, showing a successful job. Thank you very much.
Okay, about this case, any comment for our panelists? Yeah, I'd like to ask Dr. Suena for this quite difficult cases. So, do you have to perform any sudden scan to see the myocardium is still morbidity or non-morbidity, reversible or irreversible?
So actually, we don't check the viability. Yeah, no, we don't check.
Yes.
And
So-
as for this case, in United States or also in our hospital, we will consult the cardiovascular surgeon about the cabbage or not, or give any idea from the surgeon.
Already, patient have a bypass, and the bypass cover just a very distal area. So our target just want to, better blood supply to the LED proximal area. So including the first septal area. So this is just our purpose to the PCI. Of course, we have some strict stenosis in the circumference mid, and we have some small vessel cover the lateral area. So want to open the circumference mid. Of course, if we can open up the all circumference is okay, but this is maybe I think a 10 years history of the occluded instant area. So touch, and then if you can feel difficulty, just open the circumference mid, and then want to open up the proximal area of the LED. This is just our plan.
Okay, great. So I think that this case is the typical example of the cheap cases encountered the daily clinical PCI practice. So if we consider this patient will do PCI, definitely some sort of a high risk PCI. I think this case is a very nice candidate for the ventricular supported devices assisted PCI. Yes.
Okay, thank you very much. Actually, after this video and after my presentation, maybe I think everyone can easily understand the mechanism of Impella. But anyway, let's start the video. And then at the first stage, this is one of the important points: prepare and priming the Impella. My job is just to explain how to prepare the Impella. This is just 3 minutes. Okay.
So thank you very much. So first of all, in order to utilize the Impella, of course, we have to insert the rushes. In this case, we use the Impella CP, so the sheet should be the 14 French. It's quite big. At that time, there are 2 important points. First one is the puncture site, and the second one is the using the dilator as much as possible. So in order to puncture the right portion, there are some methodologies: sono guide, pro guide, and someone CP guide. The most popular one is the pro guide. You have to be sure to puncture above the bifurcation. Otherwise, the patient will suffer from the limb ischemia after insertion of the H. And also, there are some complications of the breathing. Basically, after the insertion of the Impella, there are a lot of the breathing complications as reported. Once after insertion of big piece, we can advance the 3-5 wire, and then we can advance the pigtail. Then once we can cross the aortic bar with the pigtail. Then we have to be sure about the position of the pigtail. Basically, if we advance the pigtail, it tends to be the position the lateral side. So to put the Impella, we have to advance the pigtail to the apical. So we have to rotate the pigtail the clockwise rotation. Then as we can put the pick to the right position, we can advance the dedicated wire to advance the Impella catheter.
Yeah, I'd like to ask you one question because the diabetes with hemodialysis is a high incidence of peripheral artery disease. So before the implantation of Impella, do you check the peripheral artery by CT scan or Doppler, anything else?
Yeah, if we have time to check the puncture site and then the access site, it's better to check as much as possible. But sometimes, actually, for the patient who need hemodynamic support, it should be the acute phase and the very emergent case. At that time, in order to check the puncture site as first as possible, you can use also sono guide.
Okay. That's okay. Because like a TAVI, we used to check your implanting root. Left side, right side is a pattern and big enough.
Actually, I think Dr. Chan's comment is very relevant. And for me, maybe usually when I do the coronary angiogram, I will routinely do just a brief aortogram to make sure the bilateral iliac artery is a good size enough for this kind of Impella.
Yeah, because from history, the case have the leg ulcer, this is severe. PLD maybe occur for both the below knee and the artery.
Once we advance the Impella, following the monitor, which shows the position of the Impella catheter, we can follow the monitor. Then we can adjust the position of the catheter.
Okay. So now preparing, finished preparing Impella and then start the PCI. Actually, do you have any question about the preparing Impella? Of course.
I think this is a very nice demonstration showing how can we prepare the Impella is from the puncture and the insertion of the Impella. Any question from the panel?
I'm Dr. John from India.
Okay.
That internal diameter of 6 millimeters is mandatory, right? If you want to pass a 2.5 Impella. And if you want to use higher versions, I think you need to have a minimum internal diameter of 7 millimeters.
Yeah.
And do you usually prime the LV with a flush of 250 or 500 ml of saline before you advance Impella?
Yeah.
Do you have to give volume
Volume
before advancing the Impella into the LV?
I don't think so.
Oh,
We don't need to fill the elbow as much as possible.
Yes. Okay. And anyway, the most important point is checking LV. If the patient have a inside the LV, if the patient have a thrombus, this is very, absolute contraindication. So check the inside of the LV is important, and check the route for advancing Impella, like femoral artery or around this iliac artery. Checking iliac artery is very important. So this too is the most important part.
And for advancing the Impella sheath, do you use an Ambulactor extra stiff wire or a Lundquist wire?
Basically, we use the radifocus wire, hydrophilic one.
Hydrophilic one, yeah.
So you don't need a stiff wire to advance the sheath?
No,
to advance the sheath.
Just for the pigtail in the elbow, we don't need so much support.
Okay, no, for the sheath, for the initial sheath.
Initial sheath, we have the dedicated wire, stiff wire.
That is a stiff wire, right?
Yeah.
Because here we are advised to use the Ambulactor extra stiff.
Okay, so my one question is that during the Impella assisted PCI, how can you do heparinization? You're gonna maintain the APTT, the value more than 250 or any other criteria?
So we usually check the ACT. About
ACT, yeah.
300.
300.
Yeah.
Okay.
Okay.
For this point, I think actually the company recommend you don't remove the dilator unless the ACT has reached more than 300. I mean, when you insert the sheath with the dilator, because they are afraid that when you remove the dilator from the sheath, there may be blood accumulating inside the sheath. So always check ACT and make sure it's higher than 300 before you remove the dilator from the sheath.
Okay. At least 300. Okay, good.
Yep.
This is also important.
And ProGlide, you use 1 or 2? The ProGlide pre-closure.
So if the case is not acute one, we can put the ProGlide before the insertion of the sheath. But so if we do not have enough time on the before the insertion of the big sheath, we usually ask the surgeon to remove the Impella after the stabilization of the patient.
Oh, okay.
Okay, go ahead.
Okay. So, started
Yeah, one question. In some my cases with the hemodialysis, you like this kid, but usually combined with the valvular calcification stenosis. So first, you should be careful how to close the impella without damage or obstruction of the valvular stenosis or valvular calcification to cause further distal embolization.
yes, this is also important point.
Great,
So actually, advance in Corsair, and then I want to check the condition of the distal instant restenosis. Using field IC, and then advance in Corsair, and then using Gaia first. これチェックした。で、リナートと20の風船と 2.5 のカッティング。Actually, we check the stiffness of the distal part, and this stiffness is actually too much. So I gave up to open up the all distal part of the instant stenosis area. So because our main target is LED. When you are first checking stiffness of the distal part, this is a Gaia first. From my long-time CTO experience, I feel this is not so good for the open up the, the circumference area. So maybe I think around the 5 minutes, I just touch and push, but this is not good. This is Gaia first. And if you look at the stent area, I think wire is a little bit deviated.
So Dr. Nakamura, so you are using an extremely low frame rate during this CTO intervention.
Yes.
Is it your purpose to reduce the radiation?
But actually, from the beginning, I just want to, doing a procedure very short time. Like actually, this video is 40 minutes, but actually, this procedure time is 70 minutes. And if you check the position of your guide wire in the circus distal area, better to using RAO view. So now you can see clearly distal circumference.
Dr. Nakamura, how long is the duration of the CTO? I mean, the history of the CTO?
10 years.
It's almost 10 years. Thank you.
Only?
No. I didn't say only. It's already.
Already 10 years.
Yeah.
Ask Dr. Nakamura, for your Impella from the right femoral artery, right?
Right femoral, yeah.
Yes.
Yeah, it's from the femoral artery. How about the CTO? Is it transradial CTO?
The left femoral, from the left femoral.
Left.
Left femoral. But how about
Left.
I don't know, you experience with retrograde. You need both sides. So the left femoral and right radial.
Actually, this is the HD patient.
Good. So my question is some complex question during the Impella assisted high risk PCI. Is it sometimes happen the ventricular fibrillation?
So far, we don't have not so much experience like this, but maybe maybe possible. 2.5のカッティングでもいいや。2.5のカッティング。Now you can see this stenosis.
Okay.
Of course, this actually not so big, but this vessel is covered by the lateral area. So just want to dilate here, and then want to go to the LED.
So any panel comment, and if the ventricular fibrillation happen during the Impella assisted PCI, is a cardiac compression would be okay? You know, if you think about ECMO or IVP, and any catheter part does not pass the LV, but Impella is the Impella catheter was the penetrate, cross the LV. So I'm concerned about if some urgent CPR situation is a cardiac compression, would it be okay? Any injury of LV or something like that? Any comment from the panel or?
DCB の 2.5. How do you think, Dr. Park?
So it's we don't have much experience. Yeah.
I think one of the possible reasons is only if the Impella is irritating the LV, mechanical irritation. Otherwise, the mean arterial pressure is elevated, and coronary perfusion should be good, right? With the Impella.
Okay, good.
So actually, already open up and then using a DCB.
Okay.
Currently in Japan, we use a lot of number of the DCB.
So, Dr. Nakamura, why did you choose the DCB instead of stenting in this area?
Actually, this is very complex and low ejection fraction. The too much, number of the risk factor of the stent thrombosis. Just we don't want to implant the stent. Actually, I'm a stent mania actually, but even me, I don't want to.
So you worry about the adopted duration after PCI? In this case, like a hemodialysis patient?
Just worry about the stent thrombosis. Actually, now open up. Of course, if we can see some severe dissection, stent, but clearly open up this middle of the circumference area. So One finish circumference area, and then go to the LED.
Dr. Nakamura, I have a question. After insertion Impella, the Impella device is positioned across LT valve, so I think it can make LT negotiation. Did you have any experience significant AR during Impella support?
Actually, for the patient with atrial valve regurgitation,
Yes.
Impella is not so supportive. But after insertion of the Impella, even if you have atrial regurgitation, it's not so severe. Basically. So basically, there are no, it's not so frequent, but the patient suffer from the atrial regurgitation hemodynamically. It's quite
So
stable.
usually and the inpatient severe AR, the IVP insertion was contraindicated. How much Impella? Is it moderate AR or mild AR? Insertion of Impella would be okay, or some?
You can use.
Good. That would be very helpful to audience, to understand.
I think as far as I know, for IBP, ECMO, severe AR may be really contraindicated.
Yeah.
But
Absolutely.
Impella, yes, actually Impella would be the only device that you can consider in that case.
Oh, good. Yeah, very nice comment.
Yeah.
And already advanced Corsair here. And actually our target is around here, but actually this wire should be inside of the true lumen. Otherwise, just to make a dissection around here. So want to reach the distal part of the covered area by the liver. Anyway, this wire is outside the true lumen. Just ballooning is not so good. So want to reach the distal area.
So that is my intuitive thinking, and in Japan, in the CTO intervention is really number one renowned interventionist in the world. There are many CTO yeah. So my thinking is about the ejection fraction less than 30%. If intervention cardiologists want to treat the CTO, I think Impella would be supported, assisted. The CTO intervention would be good option for low ejection fraction, or severe the hemodynamic is a condition is feasible. If this case looks very stable, during the Impella assist device,
Yeah, Dr. Park's suggestion is a very important point. It's actually very important point. I saw many times, we have a many meeting about the CTO in Japan, and I saw many times during the CTO, low ejection fraction patient collapse. I saw many times actually. So low ejection fraction patient, maybe I think using Impella is one of the good option.
Great.
Yeah, Dr. Nakamura, you mentioned, in Japan, do you need to get approval or application of the Impella before the PCI?
No. So institute need a license.
So, Dr. Nakamura, in this case, so if you are very successful in opening up the whole LAD, would you worry about any competitive flow between the LAD and also the graft, so that it will accelerate the occlusion of the graft?
No. The point is wire should be inside the lumen, and then we need to use this wire for ballooning proximal area. If the wire is outside and then ballooning around here, and then just we make so now this is a lateral view. So and then this. So actually wire This is just from gut feeling. And then wire going to the LED distal lumen, and then you can use this wire without considering any complication around here. Of course, target is proximal part, but the wire should be inside.
Yes, I understand that. Thank you. But actually, I am asking if you
don't want to direct here, just want to direct proximal part.
I understand. So you only want to improve the perfusion at the proximal part.
Yes.
Yeah, for the distal, so let the graft do its work.
Yes.
Okay.
Because otherwise, bypass surgeon very angry.
So we can get a complete devasculation hold always. Maybe we have the competent floor.
Actually, これなんかどっちかというと、そしたら only this is one shot to confirm the distal. なんかロータブレーターどうのこのっていう。
Good, excellent.
Want to advance the corsia, but the corsia stop here. So no way. Using we need to use a Gaia fast wire, and then direct just proximal to the mid of the LED. ドリルインするやつなんで、あんまりバックアップが絶対いるわけじゃないんで。
So, Dr. Nakamura, even under the support of the Impella, the patient hemodynamic collapse, do you exchange Impella to ECMO, or do you combine the Impella with ECMO?
Always we are thinking. If the patient collapses, always we are thinking.
But from the beginning, this patient had a very impaired ejection fraction around 30. If we try to support this patient just with the ECMO alone, the patient would suffer from the congestive heart failure in the future.
Yeah.
So
yes,
we need to put the ECMO. It means that we need to keep the Impella.
Of course, maybe I think after my presentation, you can understand.
Okay, thank you.
Okay, great.
So actually, looks happy face.
Good.
Because just pass. This is all the intervention carries the instinct actually. After passing, happy.
Good.
Okay, this is one of the jokes. Just balloon 1.5 and then 手前をどれくらいできるかってことだったんだな。Actually, of course, this is also instant responses part. Anyway, 10 years. After 2.0 balloon, we use IVAS. Maybe I think you can understand after the IVAS checking. $1.5 balloon is here.
Okay, good. During the whole procedure, blood pressure is good and heart rate is good.
Yes, this is point, yeah. ちょっと14。お尻も見せて、ワイのお尻見せて。So actually, last year, Professor Moses presented a paper of the Protect 3 trial. Actually, Protect in the intervention by Impella, it's very useful.
14デフェート14デフェート14緩んでたかな、はい、14デフェート14
残り13分。はい。
デフェート14
もう、just leave it advance.
もう石みたいに硬くな、棺桶みたいな。
はい。This is 2.0 balloon.
もうそれでもう
This is 2.0. Then
じゃあ超音波しよう。
now you can understand a little bit better flow the septal branch. And we check the IVUS.
ミトもカッティングして。
Now IVUS.
あ、違うかもね。
It's nearly encircling calcium. Wow.
Yeah, circling calcium. It's actually superficial circling calcium.
あ、何これ。
This is maybe I think a neoatherosclerotic superficial calcified part.
表面の石灰化ってことこれ。いや、それなりに開いてんの。それなりに開いてるってことこれ。
Actually, the IVUS catheter is at the center of the vessel. It's not touching at the wall. So maybe rotablation is not very effective. So, Dr. Nakamura, did you consider using like shockwave balloon in this case?
Well, I'm sorry. I have an experience with shockwave 4 years, but not available in Japan. And of course, we have supported Impella, but if we can direct by the cutting balloon, maybe I think we want to use a cutting balloon. So actually, very proximal part, we have a stenotic part, circling part, here.
10、12、14。
This is 2.5 cutting. Very high pressure. 16から。
じゃあもう一回。
16 atmosphere.
もう一回。14。16。はい、デフレート。これだよね。14、16。
Dr. Park, do you use high pressure cutting?
Usually in the current recommendation cutting balloon is 6 ATM or 8 ATM in the. So sometimes we're gonna use the 12 or 14 ATM that was recommended Antonio Colombo. Yeah, although and the labeling is allowed the 6 ATM, 7 ATM, but Colombo he recommended 20 ATM would be okay. Yeah,
but actually the point is half undersize cutting balloon, and then very high pressure. Just a small, cutting edge.
Cutting balloon, yeah.
これもう
この後アイバスかね。
じゃあ14、16。
残り分。
デフレート。
It's good. It's good.
ちょっと見てみようか。
And this is IVUS after 2.5 cutting, high pressure.
ちょっと見る？今の。ちょっといけるところまで。 これさっきのとこでしょ。はい。じゃあいいよ。
Okay, there's some crack. Okay, there is some crack of calcium.
Okay, around here.
あ
Actually,
歯が立ってない。
Would you
That-
consider
that-
a block? Would you consider a block modification with a 1.5 bar? Rota bar?
no, it's actually. So please watch. Still continue. Actually, we use a 3.0 cutting. And then we
3.0.
can make we can make some small cut.
3.0 cutting. Okay.
Yeah, 3.0 cutting high pressure.
Okay.
ここだっけ。10、12、14、16、18、
24 atmosphere.
Wow, 24.
And then visually,
20。
we can see
Yeah, the pitch is quite high.
デフレート。
Are you worried about balloon entrapment there?
No,
Such
Yeah,
high
maybe rupture the balloon or something in treatment or the
I love
Great.
and I trust cutting ball.
デフレート。
Then this is IVAS after the 3.0 cutting high pressure.
同じとこからやった方が全部わかるかな。ね、はい、じゃあ行こうか。
Now you can see the crack. Two part.
Wow.
割れた後にステント入れるのはなしじゃん。TCB はエビデンスないけど、でも GCB あるか。
Then finally use the DCB 3.0. 3.0 DCB. So actually we don't have any strong evidence efficacy of the DCB in a calcified, a superficial calcified part.
What make cutting balloon is it? Which company is it? We can also use it here.
No, Boston だよね。Boston Scientific.
Okay.
はい、じゃあ4。
So, Dr. Nakamura, I understand that you use this high pressure cutting at a concentrically calcified vessel. So it seems pretty safe to me. So how about your experience in eccentric lesion? If it is heavily eccentric calcification in a vessel, would you worry about using this cutting balloon would actually rupture the soft part?
Of course. Eccentric part never use the cutting balloon.
わかりやすくいるからあんま言わないで。
Very afraid of the
とりあえずこの
rupture.
あれが切れ
Yeah, absolutely.
So currently my junior, like Dr. Mitomo,
まあでも
and all of my
ENT はまあ取ら
junior
ない
very familiar with diamond back, low tension atherectomy, cutting balloon. So in each case, maybe we have a very appropriate one. So check imaging and then select appropriate one.
一応いいよ、スキップ
This is a circular calcified part. Using cutting balloon is a safe.
もう抜いちゃうよ、みんな。
And then
Okay.
this is a final angiogram. we dilate around here. And then if we can compare the first, this is a very actually proximal part is open. This is actually our main target.
It's a proximal part is much, flow was much improved. Yeah.
Yeah.
ね。よし、じゃあそれでやめよう。はい。
Okay.
Okay, we finished. So actually,
Okay.
I also show you the pre and post chest XP, and the BNP shows very blue. So maybe I think this is a better job for us.
Okay. So I think this is a very nice case. So we after we hear the consecutive lecture from Sunao Nakamura, we will have an in-depth discussion time.
Good afternoon, my dear friend, ladies and gentlemen. First of all, I'd like to say congratulations, Complex PCI 2021. I'm very happy to join you and pleasure to share my idea. Breast fracture crisis. This is very important as an interventional cardiologist. If you do not prepare, you will got an unnecessary injury. From this meaning, Impella will be a great weapon for surviving from your crisis. As you already know, Impella has a great potential for decreasing EDP and EDV, resulting in a great decrease in O2 demand, and more importantly, great assist of the cardiac output. Looks great, sounds great, looks very powerful weapon. So maybe Japanese government are afraid of overuse, then they offer strict guideline. This is Japanese guideline. In this paper, they strongly make a point of using Impella in case of a critical cardiogenic shock, so-called crash and burn, or progressive decline despite inotropic support, sliding on inotropes. Means strongly recommend only case of a severe heart failure condition and say until pulmonary congestion is improved, blood oxidation with ECMO is necessary. And also say until RV dysfunction recover, blood circulation and LV filling with ECMO is necessary. Of course, in case of poor vascular access condition or patient have a LV thrombus, this is completely contraindication by Impella. And if the patient have a high-grade atherosclerotic aorta or critical aortic valve stenosis, this is relative contraindication. As you already know, in this decade, we have several studies to prove usefulness of the Impella in the high-risk PCI. In 2009, the Protector Farm trial, they showed the feasibility of the Impella in the high-risk PCI. And 2012, actually 10 years ago, Professor William O'Neill organized Protector 2 trial comparing IBP and Impella in terms of efficacy of the in case of high-risk PCI. This is actually very important. This is the result. Impella showed very nice curve driving down the adverse event in high-risk PCI. By the way, in 2016, we have a statement from the ACC about the mechanical circulatory support PCI. As you can see, there are 4 main families: IBP, Impella, tandem heart, and VA ECMO. Each device provides a different level of cardiac flow, and device selection should be tailored to the level of the support needed. Now you can understand their position. 2018, FDA approved Impella indication on the high-risk PCI. For expanded guideline 2019, Jeffrey Moss organized Protector 3 study, which included more than 1,000 patients undergoing elective PCI with Impella, and they pick up around 500 patients having a Protector 2-like subject and compare the historical Protector 2 data. Comparing Protector 2 patients, Protector 3 show more complex, longer lengths of the support, higher percentage of 3-vessel LED left main. As a result, this is important outcome. Protector 3 show much better outcome than the Protector 2. In 19 days, Impella gave us a much lower MACE. Finally, as you can see, because of 10 years progress of the medicine and technique and devices, in Protector 3, Impella show very nice curve driving down the adverse event in high-risk PCI. If you think about the mechanism of Impella support at heart, we need to understand basic biomechanics. So we need to understand PV loop in the human heart. I'd like to introduce Professor Keita Saku in the National Cardiovascular Center. He always gives us a very beautiful lecture. Actually, how great support Impella can do. This is a data experimental study of comparison of Impella 2.5 and Impella 5.0. The difference between Impella and IVP is, in case of IVP, if the patient collapses during PCI, IVP makes just a pressure pulse, but not so much increase in cardiac output. On the other hand, Impella can keep blood pressure, meaning can keep continuous blood pumping and keep whole body condition. This is a movie, Impella experiment in the goats. He will make the data in this model. As you can see, left show partial support, right show total support. If you look at the lower 3 movie, now you can easily understand, comprehend the 3 assist, small assist of IVP in this model. Impella have a great potential in terms of heart function. And also you can understand ECMO place some burden of patient heart. Again, actually IVP, if the patient collapses during PCI, IVP makes just a pressure pulse, but not so much increased cardiac output. On the other hand, Impella can keep blood pressure, meaning having a great potential of the support. And if you think about the inside of the Impella, which is combined therapy of the ECMO and Impella, from this experiment, we can understand Impella can cancel there's some burden of the heart. This is real meaning of the Impella recommendation. I'd like to introduce 3 cases which use Impella in the CHIP PCI. This is case of a 61-year-old gentleman with a heart failure on acute or chronic. Actually, very repetitive. 48 point of the syntax and a high EURO score and a high STS score, many coronary risk factor with IDDM, very low ejection fraction 23%, and moderately reduced renal function, high level BNP showing more than 500, very poor general status. ECG and chest X-ray, more than 60% cardiomegaly with some sign of the heart failure. ECG showed broad ST depression of V46, mean broad ischemia probably. RCA, distal CTO, LAD and SX also CTO, syntax score showing a 48 point. Because of the very poor general condition of this patient and complex CTO, we decided to use the Impella support. With this Impella support, very safely we could finish the CTO open up in a LAD and circumflex and RCA. 2 weeks after PCI, we have a beautiful picture of the chest X-ray, which shows the recovery from the heart failure and with dramatically reducing a BNP. Using appropriate supporting device in a complex case is very important. Second case, STEMI with a multivessel disease with RV infarction and critical left main lesion with a severely cultured LAD. 71-year-old gentleman and a STEM patient with RV infarction and a critical left main and severely cultured LAD. Very high value of the CPK and troponin, many of the coronary risk factor, very low ejection fraction, 27%, the severe MR, high level BNP showing more than 1,400, very poor general status. Chest X-ray and ECG, more than 60% cardiomegaly with some sign of heart failure, and the ECG shows sky high ST in a 2-3 LVF and a very depressive ST in all chest lead. RCA showing a thrombotic occlusion in the proximal. Left, as you can see, critical left main with a severely calcification. Because of this situation, we decided to use the Impella before PCI. Then started the PCI for RCA. After thrombus aspiration, ballooning and stenting, we succeeded without stress. Left system, Usually this kind of situation, we do not touch more in the same session, but now already we have an Impella support. We did PCI in the left main already with the rotor. Also, we succeeded without stress. Lesion preparation, rotor, cutting, NC balloon, and stent. 4 days after PCI, Impella was withdrawn and the patient completely recovered from the congestive heart failure. 1 week later, we saw the beautiful chest XP and showing very decreased BNP, around 100. One more, this is acute heart failure with a very severe AS and CAD, collapse due to the acute failure because of CAD and AS. Emergent valve and Impella supported PCI. This is a case of 68-old lady showing severe acute heart failure due to severe CAD and severe AS. Actually, she was controlled by another hospital. During stay in their hospital, she collapsed. And after CPR and then inserted ECMO, they offered us with the expectation of the valve and the Impella. Many of the current risk factors, but good renal function, very low ejection function, 20% with the excellent support and very severe AS having a 0.6 millimeter area. Very poor general status. Chest XP and ECG more than 65% cardiomyopathy and very severe congestion. ECG shows not so significant change under ECMO support. In case of very severe condition, got always request that quickness and quickness and quickness. We did valve with Inoue balloon, they insert Impella under ECMO support. Then if you look at the coronary, surprisingly, we have a very severe calcified lesion in the circumference LD proximal. Because of the Impella support, we did rotor and DCB. So actually stentless PCI in a circumflex. And also using a rotor and DCB stentless PCI in a LD also. This is the final figure. Chest XP on admission and 6 days later. Now you can understand our successful job. This is the image of an Impella. Heart is always thinking without complaint. Never stop moving forward. It's seriously worn out. If he can rest without any effort, like a riding taxi for a while, he definitely said, I am completely relaxed. Then he'll completely recover. Needless to say, Impella have a great potential for providing a temporary rest for walking weakened heart. And also, Impella have a great potential of covering crisis which may occur during high-risk PCI. Thank you very much.
Okay, great. It's the last slide is very impressive slide to show what was there.
Yeah, this is
okay.
Yeah, it's quite a nice demonstration. Use Impella then for the serious compromised patient. The doctor will feel comfortable during all the procedure for chip PCI. And I ask one question for Dr. Nakamura.
yes.
Usually, how many days will remove the Impella after chip PCI in your hospital?
So a very good question. Actually, my junior always afraid of the bleeding insertion. So, maybe I think always want to remove as fast as they can. So maybe I think 1 day or 2 days or sometimes 3 days later, something like this.
Yeah, okay. So like in our hospital, there's a primary PCR center. So for the AMI with shock, 3 vessels, so we perform the stage PCI. So that is the Cooper region, then we keep the Impella. Then the next day or 2 days later, we'll have the stage PCI for another serious stenotic region. Is possible?
So actually,
2 or 3 days. Then the next.
Usually, in a case of very severe case, so we like you, Janjakshin, like me, it's a very experienced old doctor. Always recommend to the young doctor, you do the stage.
Mm.
But in the case of, if we can use the Impella, we can do in the same session.
Okay. And so
ad
also
hoc.
your case three answer my question. There's a case with chip and with LT stenosis. You just get balloon dilatation, then the Impella, right? Yeah, this is suitable.
Yeah.
Okay, any question? So, and I think that this, your the 3 and 4 cases are very educational to the audience. And so if you think about the hemodynamic mechanical circulatory support, there are 3 mechanisms. One is circulatory support, some systemic perfusion. And the second is the ventricular support in the LV or RV unloading. And the third is the coronary perfusion. So if you're looking at the IBP is somewhat helpful to coronary perfusion or a little bit helpful some systemic perfusion, but not good for ventricular support. But Impella, the 3 part is helpful to circulatory support or LV unloading as well as coronary perfusion. So I think there are some more advantage compared to the IBP. And so I think the Impella would be available in many countries. Also familiar with a young interventional cardiologist would be very good, is a tool to assist the very high risk compromise the patient PCI.
Yeah, completely right. Yeah.
Okay. Okay,
I have
Dr.
one
John.
question.
Okay.
When you use that INOA balloon for BAV, how did you size it? How did you size the 20?
Actually, this is a talk. I don't know, but maybe I think around the 3 centimeters or like.
Okay.
16 millimeter.
16 millimeter.
Okay.
Okay.
Yeah, I have another question. Ask Dr. Suano. If we use the Impella 2.5, when we will decide to choose Impella 5 for which kind of patient and what indication in your experience?
So actually, we use just the Impella CP, 2.5 CP. So never use the Impella 5.0. So anyway, just the 2.5 or CP.
I think for Impella 5.0 we need central access. Am I correct?
Yes.
Yeah. So yes, basically the same in Hong Kong. I think we always use CP. Actually, I have another question: is there any role to use 2.5? I mean, it's just somehow a little bit smaller in frame size when compared to CP. But then I think in my own experience, if you really need some hemodynamic support, I always go for CP instead of 2.5.
Yes. This is also right. Yeah.
So most of patients receive the 2.5, right?
Most case CP. I mean, I use
most case CP.
CP is 4 liters, right? CP is 4 liters.
CP around the 3.5 or 4.
It should be 3.5. The maximum should be 3.5. I think in the
CP is 4 liters.
Is this the burst mode? I can't remember that. In the burst mode, there's a transient maximum output, maybe 4 liters.
So I think still the many countries not yet available the use of the Impella. So this question would be very helpful to understand its clear indication of the use of diverse different type of MCS mechanical circulatory support. This is my question to Dr. Tsunao Nakamura, and you shows a very nice case. So in your hospital, you are available is IBP, also Impella, also ECMO. 3 is available. When do you use a deeper indication? Is when do you use IBP? When do you use the Impella? When do you use the MCS? That would be very helpful to understand the situation of the optimal MCS support. Could you summarize?
Yeah, if the patient have pulmonary, the severe, like AMI, with severe pulmonary congestion, and so this kind of case, maybe I think maybe better to use with the ECMO because O2 supply is not good. But IBP, it's actually, I already show you the effort for the heart. It's not so big. So currently, if the patient is not so weakened, so use IBP in the case of MI or in the case of little bit severe condition. But if the case is a so severe condition, and then also supply is okay, so maybe use the Impella.
Okay, great. So, okay, any comment or question? So we have a little few minutes.
I think Professor Park.
Yeah,
okay,
Impella,
okay.
Yeah.
Okay, okay, go ahead.
Yeah, Impella. If you use the Impella, so actually patient safe, and also doctor safe.
Good.
Very good device.
Yeah, good.
So because in case of emergency, Impella can support us very much.
Okay.
I think I just have a quick comment. Can I have just a comment regarding Professor Park's question? I think in case of really total cardiac arrest, you need ECMO to give the full support. And on top, maybe you need Impella to decrease to unload the LV. And if you're planning for a high-risk PCI, I think Impella is the most physiological, and you always aim for use Impella. Unless cause is an issue, then you have to turn to an ECMO. For an IABP, I think basically just like Dr. Nakamura said, if the patient's heart is still preserved and you just need a little bit of support, then maybe you can consider IABP. But I think if the patient really crashed, then usually IABP is not really that very useful, and you need to switch that to an Impella.
Absolutely, it's a very nice summary. Okay. So I think the time is already past, and I think this session is a very nice session, and we learned a lot of mechanism or case-basis learning from the Professor Sunao Nakamura about everything about the Impella assisted PCI, and I think this session would be very helpful to understand audience to understand overall the Impella assisted complex PCI. And thank you joining all the moderator and all panelists, and your comment would be very helpful to understand overall things. Thank you for your attention. Thank you.
Thank you very much.
Thank you very much.
Thank you very much.